Okay. So we have a question here for you. So for a clinical trial, the sensitivity is, okay, 0.5. Specificity is 0.8. What does it mean? So read the options carefully and tell me what you think. So we have 50% sensitivity and 90% specificity. What does it mean? Does it mean that the test is a valuable test because both indicators are more than 50%? Is it a valuable test because of that? The test is worthless since it gives errors when detecting both sick and healthy subjects. The test is worthless because sensitivity is too low. Test. Statistics is a nightmare. Why? No. Actually, Dr. Nairouz. Oh, I'm really sorry for that. Actually, it's not a nightmare. It's a very nice subject to study, by the way. And, by you saying that, I think I failed today to satisfy you. Please tell me if I could help you by any way. Okay, so what do you think? So first, let's just take a look. You're welcome. I hope actually you get better today after the end of the lecture, Okay, so let's now talk about something called diagnostic test accuracy. This table looks familiar, right? We did that, a couple of minutes ago for the odds ratio and risk ratio and all this stuff, right? But this time we're talking about something else. In the previous example for the odds ratio and for the odds ratio and the risk ratio, we began with the exposure, right, and disease right here, right? Okay, so obese and non-obese and disease, disease and non-disease. Well, this time we're comparing two tests. So instead of doing exposure and disease, we have screening test or a test, and the truth means the gold standard. Gold standard. Yes, no, yes, no. Same thing. Okay, so what does it mean? The best example for that, the clear example for that in the pathology. So suppose that you want to screen for endometrial cancer. So you use the ultrasound and you use a certain cutoff point, right? Like 3 to 4 millimeters, for example, versus the gold standard, which is the endometrial biopsy or endometrial sample, right? So screening test positive means endometrial thickness is above 4 millimeters, and screening test negative means endometrial thickness less than 4 millimeters. The biopsy, you take biopsy from both groups, right? And using the histopathology, you'll be able to determine which patient got hyperplasia or cancer and which patient, doesn't have disease. Okay, then you construct your table, you create your table. Again, A, B, C, D, same order. Okay, on the first cell, this time, we have something called the true positive ladies, or true positive disease, means that the screening test was positive and those patients, actually, their histopathology as well was positive. So, voila, the ultrasound actually was accurate in detecting cancer for those population where the cutoff was above 4 millimeters, right? And okay, so this is true positive screening and positive histopathology. But sometimes ultrasound could be more than 4 millimeters, but the lady, she doesn't have anything at all, right? She might be having secretory or proliferative endometrium, or so the ultrasound here wasn't able to, actually differentiate between diseased ladies and non-diseased ladies. So actually, the ultrasound said this is a positive lady for endometrial pathology, but the histopathology said there is no actual disease right there. So we made a false positive result, right? Because the screening was positive, but this wasn't a correct positive result. This was a false positive result according to the final histopathology. But the negative disease. So the screening test was negative. Okay, the screening was negative. The ultrasound for that lady was less than 4 millimeters. Okay, but doing the histopathology at the end of the day, it came up to be positive. So we made a mistake. So the ultrasound said negative results, turned out to be negative results, but at the same time, the histopathology was positive. So that was false negative result. That's an error, right? We call it false negative result. So negative results from the screening, but these negative results were false. And lastly, we have the true negative, where this is where the ultrasound screening, the screening test, said that if the results turn out to be negative, like ultrasound less than 4 millimeters, okay, and the histopathology confirmed those results. So the histopathology as well confirmed that there is no pathology in the endometrium. Okay, now we constructed the table. Now we know what's false positive, false negative, and true positive and true negative. Okay, so what are the diagnostic test accuracy things that we need to calculate? So we need to calculate sensitivity, specificity, true positive and true negative, right? So sensitivity. Just bear with me, guys. 1 second, please. Okay, this is much better. So sensitivity. Sensitivity means the ability of the test to detect the true positive. Well, meaning that what's the ability of ultrasound to accurately detect endometrial cancer when we use the cutoff of 4? Okay. So we use the true positive, the first cell. Where's my laser pointer? The true positive, okay, divided by true positive plus false negative. This one. True positive divided by the total of women who has disease. Okay, how many ladies got the disease? For example, 100 ladies. How many ladies that the ultrasound was able to detect or to predict cancer? Say like 80. So 80 out of 100, that should be 80% sensitivity, right? And specificity the other way around is the ability of the test, ability of the ultrasound to exclude, rather than diagnose, exclude normal ladies from having endometrial cancer. Okay, how many ladies the ultrasound actually was able to say that they don't have really cancer, and that was the truth. So here we divide true negative ladies over the total of women who doesn't have the disease. So true negative divided by true negative plus false positive. Okay, those two things. So it goes right like this. Where's my pen? So bear with me. So it goes like this. Sensitivity, specificity. The first thing you should do is to construct your table. Okay, then do these arrows. Okay, so sensitivity, specificity. Okay, first thing you do is construct your table. You do like this: true positive, true negative, then false positive, false negative. As you can see, the positive in the top row and the negatives are in the bottom row. Okay, then sensitivity, specificity. This is how you remember in the exam. So sensitivity, true positive over the total, and specificity, true negative over the total. Okay, positive predictive value and negative predictive value. So, sorry, positive predictive value. The equation is so simple. Why? Because we're talking about positive. So everything in the equation will be positive. So it will be true positive divided by true positive plus false positive. Okay? And negative predictive value is the same thing, but with the negatives. So negative predictive value equals to true negative ladies, okay, divided by true negative plus false negative. Okay, so positive predictive value is the relationship between or ratio between true positive over the total positives. And negative predictive value is the ratio between true negative, okay, to the total negatives. Always, as you can see from the now we have four equations, right? We have sensitivity, specificity, positive predictive, and negative predictive, right? So every time the true values are in the numerator, right? True positive, true negative, true positive, true negative. So true values are in the denominators. So all you need to change is the denominator to get to the right equation. That's clear, guys. So now we know what sensitivity means and what specificity means. So what does it mean by reporting positive predictive and negative predictive? Positive predictive value is something good for the patient, by the way. So if I told you that the positive predictive value is 90% for the test, for the screening test, for the ultrasound. So I'm telling you, my lady, that this ultrasound machine, if you use the 4 millimeters cutoff, it has a positive predictive value of 90%, which means if your test is positive, if you, my lady, your test is positive, you have a 90% chance of, being actually a positive for cancer. And the other way for the negative, okay? I'm telling you, my lady, that this machine using cutoff 4 millimeters or less, if you got negative test results, you have 90% chance of actually not having a disease. Right? Do you know what I mean? So positive predictive and negative predictive, something actually valuable for the patient for sensitivity and specificity with the method of assessing screening test. Okay? Simple. Very easy to calculate. Something actually, there's some mnemonic with that. So as I told you, all you need for you is to construct your table, true positive, true negative, positive in the top row, false positive, false negative, sensitivity, total, specificity in total. That's it. And this is positive predictive, negative predictive. That's it. Easy, isn't it? Right? So next. This also an example for that. So could you please tell me, see how they calculated the sensitivity. So here we have 20 over 30. So 20 plus 10, yeah, right? So the total here is 30. So sensitivity true positive over true positive plus false negative, all ladies with the disease. So 20 divided by 20 plus 1, 20 divided by 32 to 3, which is 97%. when it goes like that. This means that this test actually, the sensitivity is 67%. The ability of the screening test to detect disease is 67% compared to the gold standard. Okay. So my mnemonic here. So first, could you please answer this one? Sensitivity of a clinical trial. What does it mean? Question 16. What does it mean, a sensitivity of a clinical trial? Is a ratio of sick patients diagnosed as positive. So could you please read the following statements and tell me which one is correct? Good. So the ratio of sick patients diagnosed as positive and the total number of sick patients. Simply they are, interpreting what we said in the table. So my mnemonic here, so DTI mnemonic, we're always concerned about making mistakes, right? So we're always concerned about the reporting the false positive or false negative results. The false results will recur about sensitivity more to avoid false negative results. Okay, the type 2 occur. So sensitivity and false negatives, specificity goes with the false positive. So N for N and P with P. So high sensitivity, low false negative. Low sensitivity, high false negative. So sensitivity has a lot to do with the negative, and specificity has a lot to do with the positives. Okay, sensitivity and false negatives, N for N, specificity with false positive, P for P. Okay, high sensitivity, so we're good. So we got low chance for errors. So for N with N, high sensitivity, low false negatives, low sensitivity, high false negatives. So if you have a bad test, we have high false negative results, which is a very dangerous thing. Suppose that you got a screen test, for example, for cervical cancer, and but your test that you're using is very low sensitive. That means you'll send many women home while they got a disease. You'll kill the patient, right? And the same for specificity. High specificity, so we're good. We have low false positive results, and low specificity. Low specificity means high false positive. Okay, makes sense, guys? Just because when you read something in a paper or a question in the exam, when the question tells you that this test actually has is a very low specific test. So low specificity, high false positive results. So this test actually yields high false positive results. So something that's used to measure the so now we've come to the concept of distribution. So what's used to represent the average when the data are not symmetrical? So tell me, guys, please, which test is used to get estimation of the central tendency when the data are not symmetrical? Okay, thanks. Median. So what does it mean? So guys, we're now coming back to the concept of distribution. Okay, numerical data, numerical data, numerical data. I mean ratios. I mean discrete data, continuous data. For example, weight, height, age, number of metastasis, even interval data, IQ, BMI, duration, gestational age, all those stuff. Okay, any numerical data, they have a distribution. What I mean by distribution, like this one in the middle. If I told you're a medical student, you're interested in figuring out about the scores, the performance of your colleagues okay, in your college, like supporting your fifth year medical student, and you need to, describe the average performance of your student. So we have the degrees goes from like 0 to 100. Okay, so we have most of your colleagues, they got the score like around 70, between 65 and 70. So many, like we have 10 of your colleagues actually scored 60, 67, 60, 65. We have like 20 of your colleagues scored like 70. Another 40 of your colleagues scored like 75. So this is actually what goes in the middle, right? Most of our colleagues actually are centered or circled around 65 to 70 degrees out of 100. But we have very few of our colleagues, the nerd ones actually scored approaching like 100. 5 or 6 or 7 of your colleagues scored above 90. We have 2 of your colleagues scored above 95. We have just one, nerd, actually should be a lady, one nerd female student scored 100, right? And the other way, to the other side, to the downside of this scores, we have like 6 or 7 of your colleagues scored below 50, and we have one little man here scored less than 20 over 100. So this is how the curve works. So most of the colleagues, as you can see, the height of this bell curve, are centered around the center, right? Here will be the mean, for example. We have very few of your colleagues scored high. We have very few scored less. Is that correct? Okay. If the curve looks like this, so we're perfect. We say that we're normally distributed. By meaning normally distributed, that we can use the mean to test the difference between the groups. We call that this is a normally distributed observations. Sometimes it doesn't go like this. Okay. Sometimes the data might be positively skewed or negatively skewed. This one on the left, this one on the right is not normally distributed. What does it mean? It means that most of your colleagues scored very low marks, like this. So see the height. So we have a tail right here on the right-hand side. We have very few people scored high marks, and we have very high people, very large amount of people scored very low. On the other way, on the right-hand side, when an exam is easy, we have very few people scored less, and most of your colleagues, just aced the exam. So you got above 90, for example. So this is not normally distributed. This one is not normally distributed. This one in the middle is okay, but the other ones are not okay. They're not normally distributed. Okay, are you clear with that? How do we know about the distribution? We may eyeball it like this. Okay, we may get a picture from your statistical program. Okay, and we may take a look at the distribution curve like this one. The SPSS actually can do it for you. The statistical program can do it for you. And also, there are some tests, some other statistical tests that are used to tell us whether the data are normally distributed or not. Something called Shapiro-Wilk test, for example, but you don't need to know about those stuff. But this is how we know, this is how we as a statistician know about the distribution of the observation we have. You can use some statistical test, or we can, see the picture of the curve in order to, to see whether they're normally distributed or not. So what's the big deal? Why should we know about distribution at all in the first place? Because of this table. This one, very important. If the data is normally distributed, that's the thing. If the data is not normally distributed, that's completely other thing. Okay, this is how statistical tests are designed. If the data is normally distributed, we use some tests that are called parametric test. Those ones. What does it mean by parametric test? It should be parametric test. If the data are not normally distributed, we use some tests in order to, compare between the groups called non-parametric test. Parametric means mean. So the equations of these tests, we use the mean inside. As you can see from those distribution here, from the normal distributed curve, the mean actually can represent the central tendency because the mean is not distorted. Actually, your distribution is perfectly symmetrical, meaning that you can use the mean, okay, as a summary of the central tendency. But in the non-parametric, non-normal distributed curve, okay, if the data is distorted like this, you cannot use the mean. So here the mean is just, not representative of the central tendency, as well as the other one. So we need to use something else in order to represent the central tendency, which is the median. So if you want to use the mean, that's a parametric test. If you want to use the median, it could be non-parametric test. Okay? Because here, the median actually is much better in representing the data and the central tendency rather than the mean for the not normal distributed distributions. Okay? Okay, guys, are you clear with this concept? Good. So, what about the types of parametric tests and non-parametric tests? As I told you, the data are normal distributed. So we use the parametric test, okay? So here, what do you want to do? If you want to compare the means, the mean of two numerical variables. So this column on the left-hand side actually is a list of things that you want to do, okay? I want to compare between the means of two numerical variables. Like what? Like the scores of females in the college and males in the college. So we get 100 female students, 100 male students. We get the score, the final score for each one, okay? Then we get the mean here, and we get the mean there, okay? For each group, then compare them together, okay? If the mean of women, or mean of female students is normal distributed, I mean, the observation, the data is normal distributed, but also for the male student, the data is normal distributed, so much, scores around the center and very few on the periphery, and the same for the women. So here we're good to go. We could use the normal distributed, the parametric test, like independence, two groups, t-test, or paired sample t-test. Okay? So independence means two groups. Two groups means male versus female, or third grade, fourth grade students, right? Or students from two different countries. So this is called independent two groups. Okay, so what about this one? So the first one is called independent or student t-test. Okay, so what about the next one? Paired sample t-test. This is like, we have one group of patients, but you have two observations for each patient, like ovarian reserve before drilling and after drilling. So you got those ladies, you got 100 women, then you measure the ovarian reserve, the AMH, for example, before doing laparoscopic ovarian drilling, right? Then you do the surgery, you do the operation. Then like 3 months later, you repeat the ovarian reserve test for each patient. Then you compare pre-op and post-op values. to figure out if there is any difference between the pre-op and post-operative values. This time, you use the paired sample t-test. The paired sample t-test, because each observation, each case, each lady has paired observations, right? Has two observations before operation and after operation. So same lady with two observations. You compare pre and post. This is called paired sample t-test. As you can see from this green table, every parametric test has its sister non-parametric test. Okay, so first you start with what you want to do. Okay, then is my data normal distributed or not normal distributed? If my data normal distributed, we use the parametric test. So what if my data is not normal distributed test? We need to use non-parametric test. So what's the alternative of the independent t-test, the non-parametric alternative? Something called Mann-Whitney test. Mann-Whitney test. Or it does have another name. It has another name, Wilcoxon-Ransom. I know it's very actually tough to remember all these scientific names, but you know that's how it works. Mann-Whitney test, Wilcoxon-Ransom is the non-parametric sister of the independent sample t-test. Okay, guys, and for the paired sample t-test, the non-parametric equivalent or non-parametric alternative is the Wilcoxon signed rank test, not ransom, signed rank test. So this one goes with this one, and this one goes with this one. Okay. Okay, guys, we clear to this point? This is a very important table. This is one of the most important slides today. Okay, how to choose your test. Would you like me to repeat anything from so far? Okay, I shall continue. So the next, suppose that you have so many groups, like you have colleague students from different cities around your country, from city number 1, city number 2, city number 3, and you need to compare the mean of scores, medical student scores, among those cities. So you don't have two male or female, you have more than two groups. In this circumstances, you use something called ANOVA test. So ANOVA test, which is analysis of variance, actually is the t-test for more than two groups, 3, 4, 5, 6 groups. Okay. As I said to you, that every parametric test has its system of parametric tests. So what's the alternative of the ANOVA test? Is the Kruskal-Wallis. Okay, Kruskal-Wallis test. And lastly, for the numerical data, what if you want to find a correlation between two numerical variables, like dose of labetalol versus the hypertension, the blood pressure, or dose of the chemotherapy versus the cancer size, the size of the metastasis. Again, you collect the data, then you test for the normality. You do the normality test. If your data are normally distributed, you use the Pearson correlation coefficient. If your data are not normally distributed, you use the Sperman-Rowe test or the Kendall-Tau for the ordinal data. Okay? So clear to now, guys? Okay, now we're done with this. We're done with the how to choose the best test for the numerical data. Numerical means continuous, means interval, means ratio. That's great. So what about the groups? What about the males, females versus cancer, no cancer, or exposed, not exposed group versus, cervical cancer, no cervical cancer. This time, can you see any numbers here? No numbers, no measurements. These data are categorical data, right? They're groups. Categorical means nominal, means ordinal, means the binary data, right? You can't use t-test, you can't use ANOVA, you can't use Wilkinson signed rank sum, bandwidth new test. Those Pearson correlation, you can't use those stuff to analyze the categorical data. Instead, use number percentage to describe the data, like how many lady with cancer, how many lady without cancer, number percentage, right? How many exposed, how many non-exposed. And then if you want to compare those tests together, you use chi-square test or Fisher exact test. You know the chi-square test is very simple. It's the easiest test on earth, okay? I'll show you how it works. So chi-square test. Let's get back to our table. Exposed. Yes, no, not so disease. Yes or no. Okay, so we have cell A, cell B, cell C, and cell D, right? Suppose that we have like 100 ladies, so it should be 23. 23 ladies were exposed and they had a disease, right? Also, we have here exposed ladies with no disease, they were like 27. For not exposed ladies, we have 24, and non-exposed and no disease, 26. Okay? We will compare this table to the perfect table. So this how many cells we have? We have 1, 2, 3, 4. How many ladies we have? We have 100. So we have 100 over 4 should be 25. So the perfect table should be 25, 25, 25, 25. So this is the expected data, and this is the observed data. So we compare the observed with the expected. At the end, we get the p-value. Okay, the p-value will tell us if this table, the observed table, actually is different from the expected, from the perfect table or not. More than 5%, same. Less than 5%, not the same. They're different. Simple, right? Did you get me? Did you get me, guys? If the p-value of the chi-square actually is more than 5%, we assume that all ladies are the same. There's no difference between the exposed and non-exposed. That's how you find the difference between both groups. Okay? The rule of odds ratio and relative risk is to calculate this difference, if any. Okay? Are you done with this? Please tell me, guys, chat box, if you're done with this. Am I rushing through? Am I rushing through the notes? Am I rushing through the slides? Good. Let's just keep going. Finally, today, we will discuss these types of study design. Okay, so first question. Oncologists suspect that many women diagnosed as having breast cancer also they have high levels of work-related stress. What type of design would be the best to test this possible association? Okay, I'm an oncologist. Need your answers, guys, please. So, oncologist suspects that many women diagnosed as having breast cancer. Also, at the same time, they have high level of work-related stress. What type of design would be the best to test this possible association? Randomized controlled trials, randomized crossover trials, prospective cohort study, retrospective case control study, prospective observational study. The perfect. Now, so discuss types of study design. So we have observational and experimental. What do you mean by observational and experimental? Observational, you don't do any interference with the patient. Okay, you just observe what's out there already. Yeah, I'm explaining it. Don't worry. Okay, so observational means we observe. We don't interfere. We don't give the patient any specific medications. Okay, we just let the patient go with the life, let the patient go with what we're doing, and we will, collect our data and see what's going on. Okay. So this is like prospective cohort study, case control, cross-sectional, the most common three. So give my lesson pointer. Okay. Prospective cohort study, case control, cross-sectional study. Okay. So that's the most common. There are also some less common study designs like the case series, matched case control, nested case controls, and retrospective cohort studies. Okay. And we have some, I will go through each one by one, just be with me, okay? We also have experimental studies, okay, like the RCTs. This time, this is where we actually interfere with the patient. We tell the patient, we ask the patient to take this medication or not to take this medication, to go this way or that way. So we interfere with their lives. We're in control here, okay? Like the RCTs and the quasi-experimental RCTs. First, so, the whole point of research in medicine, by the way, is concerned about two main things: exposure and effect, outcome, disease, exposure and disease, exposure and outcome, smoking and lung cancer, BRCA mutation and breast cancer, HPV infection and cervical cancer, for example. Okay, so you might observe or you might do experiments. Okay, first one, you start with the exposure, exposed and unexposed. You get 100 lady with HPV infection, they'll be the exposed, and 100 ladies with unexposed, no HPV infection, right? Then you use the time. You follow up the patient over time, over a month, over weeks, over like years and years, and then you observe how many patients got the disease from the exposed group and non-exposed group. Okay, so you follow up the patient this time, you find out that some patients, they were exposed and they got a disease, right? And some other patients were exposed, they didn't get a disease. They were okay. You could smoke forever, for example, and nothing could ever happen to you, right? Some people could smoke and they got cancer at the end of the day, right? Well, some of the people could smoke maybe for 50 years and nothing could ever happen to them, right? Unexposed, non-smokers, at the end, after 10 years, for example, some people can get lung cancer from nowhere, right? So unexposed, disease, unexposed, and no disease. When you start this way, exposed and unexposed, disease and no disease at the end. You start from exposure and end with the outcome. This is called prospective cohort study, comparative study. Okay. So this is the first thing. You can do the other way. So, based on this, you could, based on this data, exposed, unexposed, effect, and no effect, as we, discussed this earlier in this lecture, you can construct your table, okay, like this: exposed, unexposed, disease, no disease. You do A, B, C, D. You can get your risk ratio, relative risk. So basically, here, risk ratio is the main measure of association in prospective study. Okay, so we don't actually, usually we don't use the odds ratio in prospective cohort studies for some statistical reasons. It's not your business here today. So for prospective cohort study, we use the risk ratio. Okay, the other one, start retrospectively. You go to your archives in the hospital and you get the notes. You get some patients with, you go to the hospital, you select some patients with lung cancer and no lung cancer, okay? And then you review the notes, you take history from the patient, you go back in time, okay? What was he doing, sir, like 20 years earlier? Have you ever worked in a factory? Have you ever smoked before, like this? Or you go to the notes of the patient to study the exposure of desire, smoking. So you start with the effect and no effect. This time we started with disease. The beginning of your study with cancer and no cancer, not the other way, not smoking and no smoking. This is very important for you to get to the right answer in the exam. This time you started with disease, the end of the day, okay? And then you go back in time to see how many cancer patients were smokers, how many cancer patients were not smokers, how many healthy population, healthy patients were not smokers, and etc. This type of study is called retrospective case control. Case control. Case means disease. This case of the patients. Control means no disease, no patients. Case control, retrospective comparative study. Okay, so the main difference between prospective cohort and retrospective case control is the point of the beginning. In prospective cohort study, you begin with exposure and non-exposure. Retrospective, you start with the final result, effect and no effect. Clear to now, guys? Just bear with me for a second. Okay, are you clear, guys, to now? You're sleeping. Are you sleeping or something? You're tired, so we're about to finish. But just help me, please. Okay, thank you. So, third one. So this is the main difference between retrospective case control, okay? And retrospective study, the main measure will be the odds ratio. So in prospective cohort, we use the risk ratio, and retrospective cohort study, we use the odds ratio. Okay, so the main measure of association in retrospective case controlled studies should be odds ratio, ADBC, ADBC. So again, you construct your table, you do your A's and B's and C's and D's, okay, and you calculate the odds ratio. Good. Third example. Okay, so what's changed this time? What's changed this time? What has changed this time? Nothing. Just there is no time. The line of time disappeared, right? So you get the exposed, and you see if effect, no effect. Unexposed, effect, and no effect. This is like Together, yes, together. This is like you're doing a screening for ladies with HPV and cervical cancer at the same time. So come on, lady, you do your screening test for HPV, then you do your cytology, okay? And you see how many patients, HPV and cancer today at the same time, how many patients with HPV infection today and no cancer, and the same for unexposed patients. So come on, lady, I'll do HPV screening for you and you see whether you got cancer or not. So you lady, you don't have HPV infection, but I do the cytology, you got cancer. And other ladies, no HPV and no cancer, right? But there is no time. We're not studying the effect of exposure over time. Another perfect example for this, use the endometrial thick postmenopausal bleeding and endometrial cancer. A lady comes to you in your clinic. She comes complaining of postmenopausal bleeding. Now, you do your test. You do the endometrial biopsy using Pipel or something, okay? And that lady, she got cancer. Other ladies, you don't get anything. And you do screening for asymptomatic patients with no PMB. This lady got cancer. This lady doesn't. She doesn't have cancer, right? Did you study the effects of postmenopausal bleeding over time? No, you didn't. You're just seeing what's going on there. The prevalence of cancer among ladies with postmenopausal bleeding versus prevalence of ladies with no postmenopausal bleeding, right? This is cross-sectional study. If there is no time between exposure and effects, cross-sectional studies. If you don't follow up the patient over time, or if you don't go back in time studying the case notes, studying the history of the patient like over years before, this is not a prospective, this is not a case control, this is cross-sectional studies. Very perfect for detecting the prevalence, but you cannot use cross-sectional studies to calculate risk ratio and odds ratio. Yes, it will work. Mathematically, you can construct your table as before, and you calculate risk ratio and odds ratio. But clinically speaking, okay, this is invalid. You cannot use cross-sectional studies to calculate risk ratio and odds ratio. You know, statistically, mathematically, it will work, okay? But clinically, the clinical implications for this will be invalid because you didn't study the effect of exposure over time, right? That's clear, guys. So they're not suitable to measure the association. I mean, they're not suitable to calculate risk ratio and odds ratio and to draw some clinical implications, some clinical value from your numbers, okay? They're perfect in finding the prevalence or prevalence comparison between exposed and unexposed. So what's the prevalence of cancer among women with postmenopausal bleeding? What is the prevalence of cancer among women with no postmenopausal bleeding, with asymptomatic women, okay? But you cannot do the odds ratio and risk ratio. Mathematically, yes, but clinically, no, okay? Clear, guys? Good. Next one. So cross-section. So this is a very important example. Actually, it will elaborate many of your confusion. Okay, you got 1,000 lady with postmenopausal bleeding. You obtained Pipel biopsy. The number of women with cancer was 100. Okay, so the prevalence of cancer is 10%. This is cross-sectional study. Cross-sectional study. We didn't study the effect of PMB over time, but we studied the prevalence of cancer among women with PMB at the same time. At the entrance, I'll tell you, Dr. Hani, just in a minute. Okay? So be with me for a second, please. Okay, the next one, this one actually is a bit tricky. Could you please tell me about your thoughts about it. Think about it. After 10 years, so now you finished with your prevalence, your 10% thing, okay? After 10 years, a new gene was discovered for endometrial cancer. And you need to find out if your patients actually expressed this gene or not, like BRCA gene, like HER2 gene, any of that. So you turn back here, you go back to your laboratory, okay, and you get back to your 1,000 slides from the patient to study this new gene expression. So what kind of study? There's a trick. Okay, actually, I saw this question, one of the textbooks, but I don't recall which book was that. We are in year 2021, and in year 2011, for example, this is your first study, okay? You take like samples here, okay? Then you finish your study, then you freeze those samples. So those samples actually, in 2021, they are 10 years old. In 2021, a new gene was discovered. So you go back to 2011 and study the new gene expression over the 2011 sample. Now, my question is, did you study the effects of time? Did you study the effect of time over your samples? It should be like this. So we have 1,000 lady, 100 got cancer, 100, okay, the 900 no cancer. At the same time, okay, we do the gene expression. No expression, yes for expression. No expression, yes for expression. Same time. If there's any time between gene expression and cancer, tell me. No. So what is it? Did you study the effect? Did you start with those ladies got expressed the gene, those ladies didn't express the gene, then I followed them by time over 10 years or so, and will end with cancer or no cancer? Yes, Dr. Haley, correct. Still cross-section study. Think of it. Cross-section study is like, if I had that facility 10 years ago, I'd be doing the gene suppression at the same time with doing the pupil biopsy, right? But I didn't have, back in 10 years later, 10 years older, back at that time, we didn't have the ability to do this expression, gene expression. We didn't have the technology to, investigate those ladies for that gene expression, right? So, but if we had that facility, we could have done that, right? So that was a tricky question. Do you know what I mean? Did you get me? Yes, it's very tricky. But get back to the basics. If you're studying all of them at the same time, all of them, the disease, no disease, and exposure, no exposure, all at the same time, no matter the trickiness of the question is, okay? All at the same time, okay? This is the cross-section study. Anytime you see a follow-up or, go back in history, using case notes or so, okay? That'd be case controls. So let's just keep going. So RCTs. So we're done with the observational studies. Okay, we're done with the observational studies. RCTs. So now we're doing experiments. Now we're doing experiment. What do I mean by this? Experiment means I'm not allowing the patient to, to go along with his life. I will interfere. I'll ask the patient to go this way and that way. Okay. So in RCTs, there's some terms that you should know about. So a term like this one, randomization. Patients are randomly allocated to either arm. So we have like placebo versus paracetamol, for example. I got 1,000 ladies, okay? 500, they will go for placebo, for no treatment, and the other 500 ladies will go for paracetamol, suppose, for example, before doing hysteroscopy or so, okay? This is called randomization. By randomization, I mean I didn't ask this particular patient to go this way or that way. No, I roll the dice, for example, randomly choosing, okay? And now we have many computer generators program, can generate random number sequence for each patient. So I'll randomly choose patients into either arms, okay? It must be done like this, using random number generator programs, okay? And you use something called allocation concealment. What's this? The patient will receive closed envelopes, which will tell them which group they will be into. This will happen blinding. So blinding is an integral part of the RCT. So randomization and blinding, those are two important terms in any design of RCT, randomization and blinding, okay? So single blinded, the patient doesn't know, okay? So the patient doesn't know which drug she will take, the placebo or the paracetamol. She doesn't know, okay? She would be taken anonymously, unlabeled medicine, okay, before the operation. She doesn't know whether this is a placebo or actual paracetamol. By using allocation concealment, they will help the patient, they will help the process of blinding, okay? Double-blinded, neither the patient nor the researchers do know about the placebo. So, for example, I'm the researcher that is doing this study. I don't know, the patient doesn't know whether she's going to take the placebo or the medicine, okay? And neither do I. I don't know either, which is this lady, the lady that's in front of me now, she's going this way or that way. I don't know. This is called double-blinded. Triple-blinded, neither the patient nor the researchers don't know that, or actually the administrator of the treatment. Sometimes your study, your research, actually the research team, you have like 10 people working for you in the research team. You have some junior trainees, they're responsible for, telling the patient, giving the treatment to the patient by hand, for example. So the three of us doesn't know anything about which treatment the patient will take. The patient, the researcher, and the administrator of the treatment, all of us, we don't know about which group the patient will be into. Okay, and the allocation concealment will help on this blinding. So somebody will put random medicine into an closed envelope, okay, and will give to the patient. Or somebody will take a random number, okay, print it on the paper, put it in a dark black envelope, and give to the patient. We don't know what's going on. Okay, so randomization and blinding, important for accurate studies. So what's the difference between RCT and cohort study? This is a very important concept for you to understand in order to get it right in the exam, okay? Cohort study and RCT, they're both prospective. Both are prospective, right? And both, they start with the exposure and end with the effect over time here, over time there, right? Right? We start with disease and treatment, no treatment, smoking, no smoking, for example, and do we follow up the patient over several months, over several years. At the end of the day, you will end with disease and no disease, right? So what's the difference? They look like similar, right? No. Observational, you're just observing the patient. You're not going to tell the patient to take this one or that one. Suppose that those ladies are using COCs, for example. They're using paracetamol. Did I tell them to take paracetamol? No. This is the gold standard of treatment. This is the standard treatment for this condition. In the case of RCT, it's me who's controlling which patient will take this one or that one. I am telling the patients, you ladies, this group will take this medicine, and that group will take placebo, that medicine. Okay? Did you get me, guys? An example for that. So women taking COCs and POBs and the risk of breast cancer. So it's not you who told the patient to take COCs or POBs, okay? You're interested in which one is better, COCs or POBs for, decreasing the risk of for which one is, will increase the risk of the patient to get breast cancer, COCs or POBs. So you go to your hospital or your regional register, and please give me a list of the patients who are taking COCs, a list of the patients who are taking POBs, okay? And you contact those patients and you follow them this time, okay? After 10 years, for example, you see how many COCs patients got cancer, how many POBs patients got cancer, breast cancer, for example. I didn't tell those patients to take this one or that one. It wasn't me. It was the GP, it was the women health authority or their standard care of treatment, or maybe taking it over the counter, for example. It wasn't me. For the RCTs, I'm interested in doing that. I'm in control. I will collect 1,000 ladies who are not taking anything at all. They're not taking anything. They're not on COC, they're not POBs. And we'll start fresh from here. Do randomization, do the blinding. You ladies, this group will take COCs. This group will take POBs, for example. Follow up in time and see which one will get breast cancer, for example. Okay. Okay, welcome. What is quasi-experimental? Quasi, do you know what the word means? Quasi, this weird looking, sort of thing. Quasi means semi-experimental. So we're not comparing this one with the Cohort. We're comparing quasi-experimental with the RCT, because in some of the textbooks it's called quasi-RCT. So we have RCT and semi-RCT, or quasi-RCT, or quasi-experimental study. So they're both prospective. They both start with the exposure and the end with the effect, right? And quasi-experimental study, same, experimental. So we are in control. We are telling which patient will take this one or that one through randomization. For this time, in this occasion, they are not randomized. That's the main difference between RCTs and quasi-experimental. Quasi-experimental, they're not randomized. They're not randomized at all. Now, there is some fault in the design that it's me who I know which patient took this one and that one. No randomization. Randomization actually decreases the risk of bias. But sometimes randomization is not suitable for every kind of study. You can't actually do that sometimes. Okay. So the main difference between this one and that one is randomization. Case series. So the non-comparative study. They don't test the hypothesis. They are perfect. Dr. Hani, you're asking about me for that actually a couple of minutes ago. So please, so perfect for identification of the incidence, okay? So you can explore the exposure effect relationship after that. So please focus. This is very important concept in the methodology and study design, okay? So you start with the exposed group. So this time you're starting with exposed group. You get like very big number of the patient, like women, like you get 1 million women, okay? So you suppose here that gender or sex is an exposure, okay? Then you follow up those ladies over time, okay? You end with effect and no effect, like breast cancer. Suppose that you need to know the incidence of breast cancer among ladies, okay? So you go to the national register. For example, the case series, by the way, they need very large number of patients, okay, like 1 million or so, okay, and over long period of time. You follow those ladies. There is no other group, right? Can you see other group? No groups, just one group, exposed ladies, for example. You follow those ladies over time to see whether they develop cancer or not. Okay. This is case series non-comparative study. So perfect for the incidence. What is the incidence of getting breast cancer among ladies using COC? I just need to take this call, guys. Just please me for a second, please. Okay, guys, so sorry about that. So the exposed and non-exposed patients, so exposed effect, exposed no effect, okay? As I told you, like the example of women taking COCs and the incidence of breast cancer, for example, women with myelina, for example, and the incidence of breast cancer, no breast cancer. So this is the case series, perfect for the incidence, no other group. Okay, so nested case control. What is this? You know, sometimes actually you could see this option among the other options in the list of options in the question. Okay, again, so you start with the case series study. So original case series study. You start with the exposed, end with the effect, right? Exposed, end with no effect. Okay, right? Then after that, after 10 years, for example, now we have disease patient and no disease patient, right? you go back in time in order to find out another exposure which is present or not. Like why those ladies got cancer, why those ladies, didn't get cancer, for example. So I'm, making a hypothesis here that some of these ladies, okay, they, for example, they were, taking higher doses or not higher doses of these COCs, or they were obese at some point of their time, or they were smokers at some point of their time. So again, so step number one, I will start with the exposed group, okay, end up with effect and no effect, okay? So women taking COCs, okay, over 10 years of time, end with cancer and no cancer. So I'm asking myself why some ladies got cancer and some ladies they didn't get cancer from the same group, from the same population that I started with. I will review their case notes. So I'm thinking that smoking might be a contributor to this result. So I'll review their case notes. I'll go back to the GP surgeries. I'll go back to the national registers, for example. Okay, review their hospital admissions. And to study the second exposure, like smoking over the results. So nested. So nested means the case control, the second study is nested within the original case series study. I'm taking samples for the same original case series study. This one is much clearer than the other one. So original case series study, 10,000 women, okay? I will prospectively explain, I will follow up in time and end up with 1,000 ladies with breast cancer and 9,000 ladies with no breast cancer, right? Then I will do the secondly nested case control study. I will take those 1,000 ladies, and I'm not going to take the whole 9,000 breast cancer. I will just take a sample from that. Well, this sample actually was from the original case. I'm not going to take any sample from outside this original population. Okay, so 1,000, go back in time. So there might be like some people using HRT, no HRT, for example. This is clear, guys. So nested case control. Okay, okay, Dr. Henny? So you're done with this. Now, are you clear with this nested case control design? Okay. So could you please, Dr. Hani, could you please elaborate a little bit more about your question? I didn't get what's your question about the prevalence? I didn't get that. Could you please repeat that again, please, for me? Yes, Dr. PL, you follow up in time from the original one and for the nested case control. So suppose that after 10 years, you got patients with cancer and patients with no cancer. So you review the notes. They are still, so now we're starting with case control. Like the case control means retrospective, right? So we go back in time, and we visit their GP surgeries. So I'm asking about those patients. What were they doing like 10 years ago? Were they smokers? Were they, have they done any surgery? Have they been exposed to radiation, for example? Okay, according to the exposure that we're interested in. So the prevalence actually, so there is no time between the prevalence, between the exposure and the outcome, okay? So incidence means you study things over time, again, but with one group, not two groups, one group. incidence of cancer among users of HRT. So you say HRT, the incidence of breast cancer, for example, is like 1,000 ladies per year. That's the incidence. Every year we register 1,000 ladies with breast cancer, for example. And the incidence might go higher and higher with users of HRT. So users of HRT, we see 2,000 ladies of breast cancer, which are using HRT per year, for example. In prevalence, I'll give you an example for this. You now want to know the prevalence of breast cancer among ladies who are using HRT. Okay, you collect 1,000 ladies that using HRT till today, and you do breast examination, for example, or mammography today. Okay, then you see how many ladies with breast cancer, no breast cancer. Did you study effect of HRT over time? No, you didn't. No, you didn't, because you don't know when did they have breast cancer. They might have breast cancer before they started using the medication, the HRT. Or they may have breast cancer like 1 day or 2 days after using the HRT, right? So this is why you can't calculate odds ratio and relative risk from cross-sectional studies. You can't actually do this. Okay? The other fancy word for prevalence in plain English is surveillance. You're doing surveillance for something. How many breast cancer, lung cancer patients among smokers? Okay, so you collect 1,000 gentlemen who are smokers. They are smokers. Then you do X-ray for everyone. Then you figure out which one got cancer, no cancer. Okay, this is called prevalence. Okay, so you don't know when the disease, has begun. Okay. So last thing to discuss today is the prospective and retrospective versus case control. This is a comparison. So we have prospective cohort, case control, and retrospective case control, right? So what is retrospective cohort study? Retrospective cohort study. So we know what we know about prospective cohort. We start with the exposure, no exposure. And for the case control, we start with the disease and no disease, right? Right? So in prospective, we start exposure and no exposure. Then we follow up the patient in time, like for 10 years or so, okay? Then we'll end with disease and no disease, like this one, 50 women using HRT, 50 women not on HRT, okay? For 5 years, how many cases of breast cancer? Yes, that's correct, Dr. Haney. Perfect. Thank you. For the case control, okay, you go to the hospital archives, you select 100 case notes, 50 with breast cancer. So we start with the end of the line, the end of the journey, the end of the story, okay? 50 with breast cancer, 50 without breast cancer. Then review the notes to see how many was on HRT or not. Go back to the case notes, ask their GPs, ask their healthcare providers about, did you prescribe CUCs for this lady or not? Show me your notes, please, from 10 years back or 5 years back. Okay, so you start with disease and no disease. So what is the retrospective cohort study? A bit tricky. So you go to the hospital archives, you select this time, okay, 100 case notes, 50 with history of HRT and 50 without history. Sorry, this should be history of HRT. So retrospective, well, we started with exposure and no exposure, not disease, no disease. Okay, clear? Not to time. Case control, there's also time, but retrospect, we study things after they happen, after they occurred. Okay, so you start with breast cancer, no breast cancer, then review the notes over the period of 5 years, for example. Did they use? They have ever used? Have they ever used HRT or not? Have they ever smoked or not? Okay, over the past 5 years, for example. Okay, no, you study time. Study time in case control and prospective cohort and retrospective cohort study. Okay, so this picture, the one that without time between exposure and outcome is the cross-sectional study. This picture is very important. Okay, so back to my laser pointer. Exposure, disease, exposure, disease. So this one, case control, you are here. So this is the beginning of the story, beginning of the journey, and this is the end of the journey. Okay, so here you started with disease and no disease. Okay, what's hidden? What is the thing that we need to investigate? Exposure. Okay, like smoking and lung cancer. Okay, so we go back in time. How many disease with exposure and no exposure? How many no disease healthy patients? Exposure, no exposure. Okay, so here, prospective cohort study. We start on the beginning of the journey. Exposed and no exposed, like patients working in a factory, patients not working in a factory, and at the end of the day, we're looking for lung asbestosis, for example. Okay. Okay, disease and no disease, lung cancer, disease and no disease. Okay, retrospective cohort. We study with, we are here today, but we go to the case notes and we make all the way back to the beginning of the journey retrospectively. Okay, we get some 100 ladies case notes with HRT users and no HRT users. Then we will make contact. We ask, so lady, we got your case notes from the hospital. You were using HRT like in 2010. So could you please tell us about your health today? Have you ever noticed that you have lump in your breast? Did you, God forbid, you got cancer or so end up with disease and no disease. Or you go to, the medical record and to figure out, which patient got cancer, no cancer. So any cohort study, you study with exposure. Any retrospective study, case control, you start with cases and controls. The end of the story. Okay. So finally, some questions. Okay, so you investigate relationship between egg consumption and heart disease. A group of patients admitted to the hospital. Okay, they admitted to the hospital with myocardial infarction were questioned about the egg consumption. A group of age and sex matched patients admitted to the fracture clinic were also questions about the egg consumption using an identical protocol. So what kind of study that is? What kind of study that is? Okay, it is case control, but which one? Perfect. Matched case control. This is your clincher here. This should be your clincher here. A group of age and sex matched patients admitted to. So matched. So we're a group of age and sex matched patients. So here, this researcher, it should be matched case control. Yeah, it's a case control, but it's matched for age and sex. So they selected the patient from the cardiology department. They got 100 men with myocardial infarction, and they matched those men with 100 other men. They went to the other department in the hospital, like the fracture clinic, for example, and they asked about their egg consumption. Okay, well, they matched. Case control studies, they are criticized by their bias, selection bias. So in order to minimize the bias of research, you need to improve your study design. You do this by matching. So matching actually will, decrease the information selection and confounding bias. Okay, so matched case control, don't, ever miss this clincher here, matched case control, matched patient to the agent sex. Good, next one. Okay, so you investigate relationship between certain solvents and cancer. All employees at the factory, all employees at the factory were questions about their exposure to industrial solvent and the amounts of length of exposure measured. These subjects were regularly monitored, and after 10 years, a copy of the death certificate for all of those who died was obtained. Okay, so you study where we started with exposure, right? This solvents thing, right? Solvent, right? And after 10 years, why retrospective, doctor? Why? This is perfect prospective cohort study. Okay, you start with the exposure to the solvent with no solvent, all right? And you ended up with cohort with cancer and no cancer according to the death certificate. Okay. Good. Next. The survey was conducted of all nurses employed at a particular hospital. Among other questions, the questionnaire asked about the grade of the nurse and whether she was satisfied with her career prospects. Okay. I'll tell you one thing. Yes, it's cross-section study. So if I'm, you're working at some place like a bank, for example, I'm doing a survey. Okay, I will get all employees in that bank and ask them. So could you please tell me about your career prospect? Or are you satisfied about your job or not? Okay, and your next one, your colleague, are you satisfied about your job or not? Are you happy to work in this place, or you screw up with this place? What do you say? So then, come on, okay, this bank, the employee in this bank, like actually 90% are happy about this career, their career, and happy to continue, and just 10% they're not happy. Okay, this is cross-section. Did we study the effective time over the career prospect? No, we didn't. Okay, so the clincher here is this word, survey. Where did it go? You're conducting survey, surveillance, as I told you, survey. Any word, survey, actually the fancy plain English word, okay, for cross-section study. Cross-section study, survey, questionnaires, all this stuff, actually they are, perfect for cross-sectional studies. Okay. So to evaluate a new back school, okay, patients with lower back pain. So back school means their school or like a health center for managing long-term consequences of back pain. Okay, so a place for treatment. So evaluate a new back school. Patients with lower back pain were randomly allocated, as I told you about random allocation thing here, to either the new school or to the conventional occupational therapy. Okay, after 3 months, there were questioned about the back pain and observed lifting weight by independent monitor. It's completely perfect example of RCT. Okay, So we were controlling so randomly allocated. We were telling this group will randomly will go to this clinic and the other group will go to the conventional clinic, right? So we didn't let the patient choose by themselves. Okay, did we? No, we didn't. Okay, we were controlled. We controlled the patient. We intervened, I mean. Okay. This one is a bit tricky. So a new triaging system has been set up at a local accident A&E department to evaluate the waiting times of the patient who were measured for 6 months and compared with the waiting times at comparable nearby hospital, which an older triaging system. So they're setting a new triaging system. Okay, they're comparing the new one in the hospital and the older one in another hospital. So they compare this one here and this one there. Okay, using the local A&E department. So the waiting time of the patients were measured, for 6 months and compared with the waiting times at comparable nearby hospital with an older triaging system. Which one is this? Jay, audit? Why? No, audit is a completely different thing. I didn't, explain audit today. Okay, but I hope I maybe sometime, later, I will do separate lecture for the audit and give you some example for that. But this is not an audit. Audit actually is about, if you have some standards and you measure your practice against those standards. Yes, comparing standard. But you don't have, we didn't specify standards here. We didn't say, Dr. Demia, if I'm, sorry if I'm not, saying your name correctly, but, standards mean that the waiting time shouldn't be more than 4 weeks. Are we up to this standard or not? This is an audit. Okay. The waiting time, for example, any lady came to the clinic with PMB, they should be investigated and treated and diagnosed within 2 weeks, the 2-week referral system in the UK. 2 weeks, right? Is our hospital up to this standard or not? Do we have any delay more than 2 weeks, or are we up to this one? This is called an audit. Okay, or we actually abide by the standards or not. But here we're comparing two systems. We set up system here and system there, and we're comparing those together over 6 months. It's not retrospective study, guys. No. So please think again. I need somebody to tell me the correct answer of this one, please. So first of all, is this prospective or retrospective study? So first, let's just right to the top, right from the beginning, okay? Right from the beginning. Is this a prospective or retrospective study? Oh, okay. Why retrospective? Why? So we are, please read the question properly. To waiting time with the patient were measured for a period of 6 months. So we were monitoring the waiting time for over the period of 6 months. How this could be retrospective? No. We didn't check with the notes. We didn't collect the data retrospectively. Okay, we didn't check the notes and go back in time for 6 months to compare between this and that. No, we were monitoring the waiting time over the period of 6 months. The presence of this past tense here doesn't mean that this is a retrospective thing. Okay, this is a prospective study. Okay, so now who's in control? Did we ask the patient to choose to go there? It's not a matched one. No, it's not a matched case control, because there is nothing in the question about matching for age and sex and other parameters. For the matched case control, they must tell you something about the matching process. So who is in control? Did we ask the patient to choose between this and that, or did we? Who did the setup? Us, right? So we intervened. We intervened. We introduced a new system like a new medication on another hospital, but we didn't ask the patient. We didn't let the patient to choose by themselves, right? Okay. So did you do any randomization here? Did we do any randomization here? Did we randomly, allocate a patient to either go to this hospital or that hospital? This is a study example. Yeah. No, we didn't. So this is quasi-experimental study. Simply put, I'll repeat the question again one more time, but in other terms. So the trick. So if you're confused, you can, replace some words like this. So this is the same question, but with amended words. So a new medication instead of a new triaging system has been set up at the local accident emergency department. Okay, she evaluated the blood pressure, for example, instead of the waiting time was recorded for the patient over the past 6 months and to compare it with an older medication. How about that? I think it's much clearer now, right? It's much nice, right? So now tell me, did we ask the patient, did we allow the patient to choose between medication themselves? No, we control, we intervene, we are doing experiment here. So experiment means trial, but we didn't control, we didn't do randomization for the patient. Okay, we knew from the beginning which patient will get this one and that one, and actually the patient themselves. So if I'm a patient, I know which medication I will get, right? So we do an experiment, but without randomization. So the trick in the previous question actually was about the wording themselves. If you're confused, try to replace the word with some other words that you already know, some other examples. So make it, you need to think quickly in the exam. If you're confused, then spend much time thinking about the question. Try some other tricks, to get around the tricky words. Try, for example, replace some confusing words with a better example for you, with an easier example for you. Okay, clear, guys? So I think, last question today. Results of a study, risk factors of cesarean section in obese ladies. This question, by the way, will evaluate your understanding of the concept of risk ratio. So the result of a study, for risk factor for cesarean section obese ladies showed that spontaneous onset of labor had a relative risk of 0.76, and the use of misoprostol for the induction of labor had a relative risk of 2.8. Which of the following statements is correct regarding to this study? First of all, in order to answer this question, you need to put your hands on the exposure and the outcome. What's the exposure and what is the outcome? So again, so we are studying the risk factors for cesarean section. Which risk factor would increase risk to get cesarean section? In obese women, so this is our population, obese ladies. So this is obese ladies, this is our population. So we are doing research on obese ladies. Show that spontaneous onset of labor, the relative risk for cesarean section, this is the outcome, is 0.76. But if you're using misoprostol, the relative risk has become 2.8 instead of 0.76. So how do you infer? So what do you think about this? Come on, guys, please quickly. No, I'm getting tired and you're tired as well, and so do you. Okay, so are you tired, right? You're tired, right? So last question. Are we happy to go? Okay, Dr. PL, yes, that's correct. So in the first number, that's 0.76 is less than 1, right? So risk ratio is less than 1. So meaning that spontaneous labor, okay, so if we let the ladies go into labor by themselves, they're less likely, yeah, they're protective from cesarean section. It's less likely to have cesarean section. But if you use misoprostol, okay, relative risk is 2.8, so it's higher in the exposed group than the non-exposed group. So ladies with induction of labor with misoprostol are 2.8 times more risk than ladies without misoprostol for induction of labor. So they're more at risk of having cesarean section, right? So A, spontaneous labor is protective, yes, because it's less than 1, correct. And misoprostol increases the risk of cesarean section. So this is based on understanding of what does it mean, how to interpret risk ratio and odds ratio. Less than 1, protective, 1 equal to each other, which is non-significant, and more than 1, exposed more than unexposed. Thank you so much for listening to me and having me today with you. I'm really sorry if I rushed through things, and I hope getting better in statistics. And you have any questions? Actually, I'm really happy to if you perfect if you drop me a line on Telegram. I'll be happy to answer your questions. Thank you so much, and yeah, thank you guys. So Dr. Humaira, don't blame yourself for that. This lecture will be recorded and will be uploaded on the YouTube, I think, and you will have it at the end of the day. Don't worry. Okay, we'll be happy. You have the chance actually to review this lecture. Okay, thank you. Okay, good night, guys. Sleep tight. Thank you so much.